pleasure to see you all gathered here on this special occasion. The first academic program conducted under the leadership of the new President and the Council. The Peer Learning Forum reflects the very essence of our college. It is a forum where we come together to share knowledge, exchange experiences, and strengthen the professional bonds that connects us each other. Here in Kandy, at this very venue, on the 13th of March 2016, a distinguished group of internal medicine consultants, and I am pleased to see many of those founding members with us here today, laid the foundation for what was then Sri Lanka Society of Internal Medicine, now proudly known as Sri Lanka College of Internal Medicine. The theme for 2026, a decade of inspiration, a future of innovation, captures both our journey over the past 10 years and our aspirations for the years ahead. To officially begin our program, I am pleased to invite Dr. Madhuvanti Hettiarachchi, President of the Sri Lanka College of Internal Medicine 2026, to deliver the welcome address. Over to you, Madhuvanti.
Good evening, everyone. It truly feels special to stand here today in Kandy this evening. And 10 years ago, as Tushari mentioned, the Sri Lanka College of Internal Medicine was founded right here in this city and the same place actually. So at that time, it was simply an idea, a dream shared by a small group of physicians who believed that we needed a professional home on our own, a space to grow, to support one another, and to raise standards of internal medicine in Sri Lanka. And today, 10 years later, we are back where it all began. That feels very meaningful also. And over the past decade, SLSIM has grown steadily with collective commitment. As Tushar mentioned, our theme this year is a decade of inspiration, a future of innovation. The inspiration came from the courage to start the innovation, and it must came from the courage to evolve. And this lesson I learned as a founder, joint secretary, and 10 years later, being the 10th president of the Sri Lanka College of Medicine. Peer learning actually reflects that true spirit of internal medicine is not about hierarchy or titles, and it's about thinking together, questioning together, and learning together, and refining our clinical judgment together. In an era where cardiometabolic diseases, multimorbidity, and complex therapeutic challenges are daily challenging us, we must grow not only individually but collectively. And I sincerely thank all our speakers today, Dr. Kumudini Jayasinghe, Professor Chamara Dalugama, and Dr. Sawandika Rupasinghe for sharing their expertise with us. And I'd like to thank Dr. Tushari Vanigaratne for moderating the session. Thank you very much for being here once again. Thank you.
Thank you very much, Madhuvanti, for the generous words. We all will hope and wish you and your council will have a very fruitful and exciting year. To start the program, our first speaker is Dr. Kumudini Jayasinghe. She doesn't need any introduction. She's one of the past presidents of Sri Lanka College of Internal Medicine and consultant physician attached to National Hospital Kandy. She would talk to us on unmasking masked hypertension. Over to you, Kumudini.
Good evening, everyone, and also happy Valentine's Day to everyone. And at the outset, I would like to thank the President and the Organizing Committee for inviting me for this first PLA for the year 2026. We'll start with the first talk, the unmasking masked hypertension. So why I've chosen this topic is this is a neglected area in hypertension, even in the guidelines. So in this talk, I'll be introduction, risk factors, and clinical implications of the masked hypertension. Then I will talk about nocturnal hypertension and especially screening and the management. Hypertension, we know, is compared to other cardiovascular risk factors, is associated with more severe target organ damage and also the cardiovascular deaths. So, though all my colleagues know the definitions and the guidelines very well, I thought of sharing this slide as well. According to the ESC guidelines, the blood pressure is defined as office blood pressure equal or more 140/90, but the out of office levels, home blood pressure monitoring, as well as the ambulatory blood pressure monitoring daytime, 5 mm lower than the office blood pressure. Nighttime mean equal or more 120/70. However, in 2025, office blood pressure is about lower than the ESC guidelines. So, office is equal or more 130/80, and also they are out of office home blood pressure monitoring, and the ambulatory daytime is equal to the office blood pressure, if you see this. And however, they are like a nighttime mean is lower than the nighttime ESC values in diagnosing hypertension. So, what is masked hypertension? Normal office blood pressure, but elevated out of office blood pressure, either home blood pressure monitoring or ambulatory blood pressure monitoring. So, this slide will show, and what I said is the office blood pressure is normal for the masked hypertension. So, the level is here. So, its office blood pressure is lower than 140/90, these according to the ESC levels, and home blood pressures and the other values are more in the masked hypertension. So, it's a home blood pressure more than 135/85, and the nighttime ambulatory more than 120/70. So, both the guideline ACC/HA recommend out of office blood pressure monitoring and diagnosing hypertension. Especially ACC/HA, they recommend and strongly recommend to use the out of office blood pressure monitoring in the diagnosis. ESC also, but they at the same time, rather than like just not only recommending, they say if it is out of office measurements are not logistically and economically feasible to use the office blood pressure monitoring, but repeated measurements with a validated automated blood pressure apparatus with the correct technique. Why this masked hypertension is underdiagnosed? Mainly because of lack of knowledge in healthcare workers. Either we don't know that there's a category like masked hypertension, or how to diagnose masked hypertension, how to suspect that the patients are having masked hypertension. Or lack of resources. Monitoring, like with the ambulatory blood pressure monitoring and the home blood pressure monitoring, are not freely available in the most of the settings, including the countries like us. And at the same time, we are not screening for target organ damage in all the hypertensives. Though it's a guideline recommendations, we practically what we do is just the controlling blood pressure. We try to start it, but we don't look at what are the target organs already damaged with the hypertension. So there are two categories of masked hypertension. In the untreated individual, you call this untreated masked hypertension. But in treated patients with hypertension, you call this treated masked hypertension or masked uncontrolled hypertension. Again, to complicate masked hypertension, there are many phenotypes. Isolated ambulatory blood pressure. only the elevated ambulatory blood pressure is there. The home blood pressure monitoring levels are normal. Some do have only the isolated home mask hypertension. In that situation, only the elevated home blood pressure monitoring levels are there, but the ambulatory blood pressure levels are normal. Some do have dual mask hypertension. In that situation, they have both the elevated ambulatory blood pressure levels and the home blood pressure levels. So that category, dual mask hypertension, has the highest cardiovascular risk. And there's another category, nocturnal mask hypertension. That is again an important subtype, but which I'm going to talk again. And in that situation, patients do have normal daytime blood pressure, but elevated nighttime blood pressure. Again, they do have a very high cardiovascular risk. Prevalence again vary. So again, untreated mask hypertension is about 11%, but can go up to 30%. Whereas the mask uncontrolled hypertension, it's again can go up to 43%. So commonly this mask hypertension that we can see in the African countries, sub-Saharan Africans, that's up to 18%. The African Americans is about to more than 52%. And the Koreans, they do have very low levels, about 5.7. Why should we treat mask hypertension? That is mainly to reduce target organ damage and also to reduce cardiovascular risk and also to prevent complications due to hypertension. Available data shows that mask hypertension has higher target organ damage than normotensives, and also their CV risk profile similar to patients with sustained hypertension. So if you look at this graph, and you can see this is sustained hypertension and this is mask hypertension in all the graphs. So this is the cardiovascular events in the untreated patients and the cardiovascular events in the treated patients. You can see both are more or less equal. So itself cardiovascular events are more or less similar to sustained hypertension. Same as in the mortality, that you can see mortality again high whether it's untreated or treated individuals. Nocturnal hypertension. This is an isolated nocturnal hypertension, is again a subtype of mask hypertension. So they do have, as I said previously, elevated nighttime blood pressure that is equal or more 120/70 according to the ESC guidelines, and normal daytime blood pressure lower than 135/85. This is again common in Asian countries, maybe due to high salt intake and also high salt sensitivity also again high. So nocturnal hypertension do have the cardiovascular and organ damage risk equal to sustained hypertension. This is strongly linked to heart failure and major cardiovascular events, associated with again the risk of left ventricular hypertrophy, atrial fibrillation and also vascular damage. This JAM study is done in Japan, has shown that it's a recent study in 2020, and it shows the nighttime blood pressure phenotype and cardiovascular prognosis, the practitioner-based nationwide study. So, according to we usually in the night time, normal people, there should be dip actually. So some do not have this dip, but some do have rise of the blood pressure. that is dangerous. Which people usually get nocturnal hypertension? The people who usually get the disturbance of the night. Sleep disorders, sleep apnea and insomnia, frequent nocturia, and also diseases such as chronic kidney disease, diabetes, insulin resistance. So increased salt intake in the night, and again autonomic dysfunction or failure. So let's again talk about the risk factors and mechanisms of masked hypertension that we have already discussed about the nighttime hypertension associated with sleep apnea, diabetes and chronic kidney disease. And again, one mechanism is like recent factors are the job stress and the lifestyle, high stressors, and maybe due to shift work or and sometimes high salt and alcohol intake, especially in men. So in the men, masked hypertension is high. And also hyperaldosteronism in treated patients. Often they have a higher level of aldosterone, indicating increased sympathetic nervous system activity. And the increased sympathetic activity also seen in categories patients such as having obstructive sleep apnea, obesity and also stressful conditions. So this is an important slide. So we do not have like we usually check the blood pressures at the office level in our settings, but which patients that we should suspect that the patients are having masked hypertension? If they are having a normal blood pressure, that is blood pressure less than 120/70, I'm talking about the ESC guidelines, and or if they are having elevated blood pressure, that is when their blood pressures is 120 to 139 systole and diastole 70 to 89 with target organ damage. So if they are having left ventricular hypertrophy, proteinuria or any other target organ damages, then you need to suspect with either normal or elevated blood pressure. Or if they are already having high cardiovascular risk, for example, if patient has a myocardial infarction or stroke with normal blood pressure, that you need to suspect. And also they have a 10-year cardiovascular risk high with a risk calculation. That ACCHA now with a new risk calculator, that is prevent risk calculator, and here in Sri Lanka what is recommended is a WHO risk calculator, and ESC it's a score 2. And other conditions such as diabetes, CKD, the obese individuals, patients with obstructive sleep apnea, and the strong family history of hypertension. Both parents are having hypertension, but that patient's blood pressures are normal. Again, that you need to suspect. And the habits of smoking, high alcohol intake, and also stressful jobs with a normal or elevated blood pressure. All these conditions, in all these conditions, we need to suspect whether the patient is having masked hypertension. So how do you screen? Either with ambulatory blood pressure monitoring or home blood pressure monitoring. This ambulatory blood pressure monitoring can detect nocturnal masked hypertension. However, most of the studies now what they say is because it's again the disturbance in the night, but it's again not one day that you are getting disturbance, but maybe in some other day. So it's not practical to check the ambulatory blood pressure monitoring only one day. So ideally it has to be frequently in many days. So it's again not a very good test to diagnose nocturnal hypertension. And again it's not cost effective and the patient tolerance is very poor. because each time this cough is inflating, that is very day-to-day, with the day-to-day activities, really difficult. And it's difficult to reproduce and use as in the follow-up as well. So it's actually not a very good test for the screening and also follow-up in the mask hypertension. So what about the home blood pressure monitoring? It's a better tolerated, but problem is that cannot detect nocturnal hypertension if you are checking only with the daytime blood pressure monitoring. So we can miss nocturnal hypertension. So we'll move to management now. This is as I said, this is a very high risk phenotype and should not be left untreated. So we need to optimize metabolic profile, treat all the modifiable risk factors such as obesity, diabetes, obstructive sleep apnea, advise on avoidance of alcohol, smoking, address stress and the social factors. Antihypertensives should be started to reduce out-of-office blood pressure and monitor response to treatment. So I'm not going to discuss these things in detail, but remember all these are important in reducing mask hypertension. Especially we have discussed about the smoking and alcohol and also weight as risk factors for mask hypertension. So it's very important to and also salt intake. So it's very important to control all this. Remember now new salt intake with the ACC/HA guidelines is less than 2,500, preferably less than 1,500. And the stress reduction with the yogas and the mindful meditation, it's again there, it's the new guidelines. And then we'll talk about the antihypertensive, because as there's a nocturnal hypertension, using one antihypertensive in the night may be useful to counteract this nocturnal hypertension. And also treat elevated blood pressure in high risk of patients with target organ damage. Normal or elevated blood pressure in high risk of patients with target organ damage. So this is our future. There's a new diagnosis tools with the AI and other wearables. So AI driven diagnosis, AI tools that analyze patient data. Now this one university in USA, they have produced one AI tool, and it actually get the patient's age, sex, lifestyle and echocardiogram, and also the likelihood of mask hypertension, roughly about 83% accuracy. So it's very easy for patients. It's a diagnosis of mask hypertension in future, hopefully. And this cuffless and wearable, again continuous cuffless sensors that can track daily blood pressure fluctuations, allowing more precise detection of nocturnal hypertension. Actually, some studies have already done in Japan, and they have seen these cuffless and the sensors usually attached to the wrist, and the patients do tolerate it very well. And all these smartwatches, though the guidelines do not recommend currently, I'm sure, because of the no adequate data, I'm sure these will come into practice in the near future. So how should we manage mask hypertension better in future? Because effective screening is important. We need a cost-effective, user-friendly blood pressure screening methods, and also the treatment guideline should be updated and to give more space and more details how to manage this mask hypertension and also white coat hypertension. So about only half of age is there for all these two. And to summarize, mask hypertension and mask uncontrolled hypertension is a common blood pressure phenotype. Risk of organ damage and cardiovascular risk is similar to sustained hypertension. Nocturnal blood pressure is a potent predictor of cardiovascular outcome. Ambulatory blood pressure monitoring is a limited access, poor tolerance, and home blood pressure monitoring is practical, validated, and better adherence. In future, it's AI-generated tools and cuffless sensors and smartwatches, and this is a home. Key takeaways: until the guidelines are made for mask hypertension, suspect and screen individuals for mask hypertension, treat risk factors for mask hypertension, and consider antihypertensives where appropriate to reduce cardiovascular risk and the target organ damage. Thank you.
Thank you very much, Dr. Kumudini Jayasinghe, for a very insightful presentation. We will go for questions at the end of all three lectures, and I would invite now Professor Chamara Dalugama, Professor in Medicine, Honorary Consultant Physician attached to Teaching Hospital, Peradeniya. He will talk of GLP-1 analogues, Incretins. Over to you, Chamara.
Good evening, and thank you very much for that introduction. And it's indeed a pleasure to be here. So, for the next 20 minutes or so, I will be talking about one of the very important fundamental molecule, important medication, which has, I would say, changed the landscape of metabolic medicine. So, without much ado, let me take you to the topic, incretins. So, we are going to explore beyond diabetes, and we are going to explore the metabolic benefits, the organ-saving benefits of incretins. So, due to the uniqueness of today's audience, it was a bit of a tedious task to make a presentation, because I thought talking a lot of physiology and pharmacology would definitely waste your time, and talking a lot of trials and evidence-based medicine on this Valentine's Day at this time would make you bored. So, I thought I would rather discuss some important clinical scenarios which would sort of give some insight to how to use incretins in day-to-day practice. So please bear with me for 2 slides with regard to the pharmacology and physiology. So if you take a man and if you give him 50 grams of oral glucose to sort of take orally, and you measure the insulin response of this patient, and then you do the same thing with intravenous glucose 50 grams. So generally, I mean, we are not surprised because we have learned this, but sometime back the doctors, the scientists were surprised to see the insulin response was far higher and much great for oral glucose compared to IV glucose. Then they were wondering how this happened. And this is because of these 2 chaps that I am going to discuss today, that is GLP-1 and GIP. So GLP-1 is secreted from the L cells of the ileum, and GIP is secreted from the K cells of the duodenum. And these 2 chaps, which are secreted in response to an oral glucose load, make the effects very glucose dependent. Therefore, it is like an auto-save-fail mechanism, where when you take a higher glucose load, the gut knows that, gut senses it, and it activates the incretin system to give a higher insulin response. Right, and diabetes and incretin effect. And this is what we see in healthy people, where they have this is IV glucose and this is oral glucose, and there's a high insulin response to oral glucose. But this very effect is blunted in diabetic patients where we need the most. So they have a very blunted response, blunted incretin response. So the GLP, what actually GLP does in our body? It does a lot of things. When you go through this, you know it's a miraculous molecule, because when a man is eating, it sort of pokes the pancreas and says, look here, this man is eating a lot, so produce more insulin, reduce the glucagon synthesis. And then it goes to the brain and tells you, no, you are eating too much. Now you are full, please cut down on what you eat. And it goes to the stomach and it gives a feeling of gastric fullness. It reduces the gastric emptying, it reduces the bowel motility. And also, it is going to the liver, fat and muscles, and it will suggest that, look here, this man is eating too much, why don't you take up the glucose in the blood? So it is multitasking, and it's doing a lot of things so that your blood glucose can be nicely managed. So then the scientists were thinking, so we should target these incretins, and we can get a good therapeutic response from this. So as I mentioned, the incretin effect is reduced in diabetic patients. So the main reason is in diabetics, they have a very blunted response because of the prolonged hypoglycemia. And this GLP-1 is something that is naturally, it is secreted by the gut, and it is very rapidly degraded by the dipeptidyl peptidase 4. This is the enzyme that breaks down GLP. Therefore, the scientists were thinking that we should target two drugs. One thing is we can inhibit the DPP-4, that we can get the maximum use of naturally occurring GLPs. And the another set of people thought, okay, no, it's not the way, but we should make a sort of a similar molecule, which is a synthetic molecule, which mimics like GLP-1, which will work on the receptors and which will give all the actions without being broken down by the DPP-4 inhibitors. So that is where we are. And from now onwards, I will take you through a few case scenarios. And I know the topic is about incretins and GLP-1 agonists specifically, but I will briefly talk about DPP-4 as well. So the first patient is a typical 52-year-old laborer that we see in our day-to-day practice. He's with a BMI of 25, and his fasting blood sugars are always normal in the clinic book. But whenever you do HbA1c, it's a bit high. And then you ask for a PPBS, and to see his post-lunch glucose spikes to 240 after eating his usual large plate of rice and paripu. But he's on metformin SR 500 milligram BD. So then what would you choose? Here we have to get the maximum use of incretins. So you can use either sitagliptin or vildagliptin, because these are very elegant choices in this sort of a scenario where it works in a very glucose-dependent manner. So it enhances the body's response to a meal and specifically targets the postprandial glucose surge. And particularly we Sri Lankans, what we are going to eat tonight as well, the carbohydrate-dense Sri Lankan diets, this is one of the very good choices. So next couple of slides I will quickly go through regarding DPP-4. So we have sitagliptin, vildagliptin and linagliptin, and just few take-home messages that this sitagliptin works for 24 hours and it needs to be prescribed as once daily drug. Sometimes we do see the patients being prescribed 50 milligram BD or 25 BD, but that just increases the patient's pill burden. So better give it as single daily dose. But when your patient is having an EGFR less than 45, you have to go for 50 milligrams. And vildagliptin has a shorter half-life compared to sitagliptin, so naturally it is dosed as twice a day, but when the EGFR is less than 45, you can give it once a day. And linagliptin, maximum is 5 milligram. Don't go beyond that, and you don't need any dose adjustments when it comes to renal failure patients. Right, so we'll come to the main part of the talk. So first, I will take your focus to a 40-year-old CEO in Colombo, and he's a diabetic patient, and he's not only suffering from high glucose, but he struggles a lot with a lot of work pressure, a lot of problems with the staff, as well as he has constant hunger, and he's frequently snacking on short eats, rolls and patties. And he's on metformin, sulfonylureas, and dapagliflozin. So what would be your next choice of hypoglycemics? So for him, a GLP receptor agonist would be an ideal choice. Something like liraglutide or semaglutide, which I will discuss, because it does a lot of things. Now this man is coming to work, and then he has a high BMI, he's trying to lose his weight, and whenever he feels the short eats, when he sees the 10 o'clock tea, he wants to have something. So this GLP will slow his gastric emptying, and it will work on the patient's brain satiety center. It will help him to sort of turn off the hunger, and it sort of make him easy to resist and say no to oil-heavy snacks, which are common in local offices. And also, it will help to get his weight down and to get his HbA1c down. Right, so prescribing GLP-1 receptor agonists. So these are the three drugs that we have. We have semaglutide as an oral tablet, starting from 3 milligram once a day, which you can gradually go up to 7 to 14 milligrams. And we have semaglutide, the parenteral preparations, which is in the form of weekly injections, starting from 0.25 weekly to 0.5 to 1 milligram weekly, and liraglutide as a daily injection, starting from 0.6 to going up to 1.2 to 1.8. Right, so I'll quickly go through how to start oral semaglutide. So always the principle is slow and steady. Sometimes patients do come to us and they request semaglutide because there's a lot of publicity given on these medications, and people read in, in internet, they go through various YouTube videos, and so they ask, doctor, why can't you give us semaglutide? Sometimes we also become very enthusiastic. We start with 3 milligram and very, very quickly we want to sort of get the maximum therapeutic response to the patient. Right, so we start from 3, then we increase it to 7 and increase it to 14, and most of the time we end up with treatment failure. So the main principle here is, if you want to start semaglutide, you have to be very patient. You start 3 milligrams, start a dose, and give at least 1 month for the stomach to adjust. And then you can go up to 7 milligrams, which is generally the maintenance dose. But if you can't achieve your HbA1c targets or the weight loss targets, certainly you can go up to 14, but all what you need is a very slow and steady titration approach. So the other thing is semaglutide, what I generally tell is, yes, take just as you take thyroxine, likewise, because it has to be taken on an empty stomach with a tiny sip of plain water. So for thyroxine, we don't use that word, you drink, take it on empty stomach. But here, if you take the semaglutide with a big glass of water, your stomach is going to be full, and that's going to make you your stomach is going to be uncomfortable. So tiny sip of plain water, empty stomach, 30 minutes before eating or taking other meds. And the other thing is, the general advice is to avoid the big dinner, the big meals, because it has already slowed your stomach gastric emptying. So if you take a big dinner, you are going to feel very uncomfortable. And then this nausea is pretty common in patients who want oral semaglutide. So taking cold water and something like Tamili is going to really help them to get rid of this uncomfortable feeling. So coming to subcutaneous semaglutide, these are general technical points where you keep it in the fridge, but when you use it in the pen, the in-use pens can be stored in the room temperature. You don't have to put the pen into the fridge. And it's the same day rule, so every week you take it on the same day, and you rotate the sites, and again it is the gradual setup protocol, starting from 0.5 at least for a few weeks, then go up to 0.25 to 0.5 to 1 milligrams. And then for liraglutide, again the same thing, in-use pens that you can keep in the room temperature. Again, gradual setup protocol. You start from 0.6 milligrams to 1.2 to 1.8. So generally the liraglutide, the injection, is like 18 milligrams is the dose, which is basically 30 doses of 0.6 milligram. So in the first month you might use 1 pen, the next month you might go up to 2 pens, and 3 pens if you need. So that is how you should be sort of titrating it up. And then this is just a very approximate cost of these medications. So because it depends on the dose that you are going to give to the patient. So liraglutide, the pre-filled syringe, there are 2 brands, then one brand will cost around 23,000 rupees to 25,000. So if you use 0.6 milligram per day dose, it will cost around 25. But if you are going to increase the dose, it's going to cost higher. Similar with oral semaglutide and injectable forms of semaglutide. Right, and this is again a new drug, tirzepatide. So this is again, I had few patients who are coming and asking, doctor, can you give, so I'm not going to tell the trade name, this drug for me, because there's a friend of mine who is working in Dubai, he has already brought this one. So I just want this need to be prescribed, and is it okay to take this medication, right? So tirzepatide is a miraculous molecule again, because it's a single molecule that activates 2 incretin receptors. So that is why it is called as incretin. It acts on the GLP receptor as well as it acts on the GIP receptor. So starting from a dose of 2.5, you can go up to a maximum dose of 15 milligrams for a very high, for a greater weight loss and HbA1c reduction. Right. So coming to the third case, this is of a 3-wheel driver. So this is a 45-year-old driver who is on sulfonylureas and who has had recent recurrent fainting feelings due to his, while driving, due to the late lunch. The time he has his lunch depends on the time that he finishes his drive. So then a DPP4 inhibitor would be an ideal choice. right? So because unlike the other drugs, the incretins, they rarely cause hypoglycemia, right? And then generally they stop working when the blood sugar returns to normal. So certain jobs where the safety sensitive jobs like driving, this would be an ideal choice given his, we have to consider both the financial cost and everything, but this would be ideal choice. Again, the DPP-4s, it's a safety first switch, so it's glucose dependent, it's driver safety, and it has an auto fail-safe mechanism, and it's weight neutral. And then we come to the fourth patient, so I will quickly go through this. I have around 9 or 10 patients. So this is a 60-year-old woman with diabetes, and she shows some early signs of breathlessness. We have asked for echo. And then her BMI is 27. She's on metformin, maximum dose of glycoside, and empagliflozin with a suboptimal control. I mean, for a patient like this, starting a GLP-1 receptor agonist would be ideal because it has other benefits, right? So one thing is this one, the MACE reduction, the major adverse cardiovascular event reduction. So they're known to reduce the major adverse cardiovascular events like MI, stroke, and cardiovascular death. And it offers a dual purpose therapy. So it manages the suboptimal HbA1c as well as it provides independent cardio protection. And it also gives organ protection. There's a lot of evidence that this GLP receptor agonists have benefits in lowering CKD progression, and it's one of the gold standard drugs for complex metabolic diseases. And then another patient. This is a 55-year-old female who is a diabetic, hypertensive, and she has very high triglycerides. And this is a typical the metabolic syndrome lady. And her biggest concern is she comes and, doctor, look here, look at, you have written the whole page of drugs to me. So can't you reduce my medications because I am having behet godak. So then GLP-1 receptor agonist can come very handy here because it aids a lot of things. It aids weight loss. It has an effect on lowering blood pressure, and it sometimes can prevent the need for additional antihypertensives or high-dose statins, and also it simplifies the pill burden of the patient. So that is why we call this has a metabolic multitasking effect. It has a lot of pleiotropic effects. Beyond glucose, it improves triglycerides, and it reduces the blood pressure as well. And also, given the injectable forms of weekly injections when it comes to semaglutide, it simplifies the regime and it improves the patient's adherence as well. Right, and then this was a recent one, a 35-year-old doctor who has got panic after getting an ultrasound scan which shows grade 2 fatty liver. So he's a type 2 diabetic, he's on metformin, HbA1c is not too bad, 7.2. His BMI is 25 but with a big belly. And that is true for most of us. I mean, our BMI is not that high, we are like 23, 24, but when you wear a tight shirt, you know how big is your bundles. So then, again for him, a GLP-1 receptor agonist would be an ideal choice because there is a lot of evidence now, there are a lot of trials that show GLP-1 agonist can help to reduce the liver fat and inflammation. Right, so the liver fat reduction, particularly the hepatic steatosis and inflammation is known to be reduced with this. And then it targets the big belly. Even with a normal BMI, the central adiposity is a major driver for grade 2 fatty liver in this patient. So it helps with the reduction of the big belly. And then there are certain trials that have shown that very promising histological improvements in liver health. It improves the hepatic steatosis. So this would be an ideal choice if you are considering a patient who is obese or who has a central obesity with fatty liver as a drug of sugar control. Right. Okay. So now coming to another case. This is a 55-year-old man with diabetes for 10 years. He's on metformin 1000 BD with sulfonylureas and acarbose. His HbA1c is 7.3. But now his creatinine has gone up to 155. So we might not completely stop metformin, but sometimes we feel uncomfortable to give him 2000 milligrams of metformin in this patient. So again, a linagliptin can come handy here because you don't need any dose reduction here. You can start linagliptin and you can sort of reduce the metformin while maintaining the blood sugar control in an optimum way. Right, so linagliptin is a renal friendly incretin. It is excreted by the bile, not by the kidneys, so you don't need any dose reduction, and certain trials have shown that they are safe in cardiovascular and renal wise, and particularly in patients who are at risk of kidney failure. Right, so this is, I think we already discussed this one. So a patient needs GLP-1 receptor agonist for weight loss. He's very interested in this, but then when you tell that this is injectable one is available, he doesn't want it because he frequently travels to work and he's scared of needles. Then the oral semaglutide is a choice of incretin, because the availability of an oral version of GLP-1 agonist, it gives the patients the benefit of incretin therapy without psychological or logistic hurdle of needles. Right. So then this is again a 35-year-old woman with a strong family history of diabetes. She has polycystic ovarian syndrome and her latest HbA1c is 6.5. I mean, for her also, if she can afford, a GLP-1 receptor agonist would be ideal, because it helps to tackle the underlying insulin resistance and it addresses the weight issues in this particular patient, and also it has the potential of delaying the progression from pre-diabetes to full-blown type 2 diabetes mellitus. So the PCOS synergy, incretins, it helps the underlying insulin resistance and the weight issues, and which can improve the underlying polycystic ovarian syndrome. Right, and coming to the last case with regard to the drugs, the elderly patient who is living alone. So this is a 75-year-old lady in a rural village. She lives alone and sometimes forgets to eat her meal on time. So for such a patient, I would consider starting a DPP-4 inhibitor as a first-line medication because of the low risk of hypoglycemia. Right, so she won't suffer a life-threatening drop in blood sugar, and that gives peace for her and for the family. So if you start a sulfonylurea, sometimes you might end up seeing this patient in the medical ward with a major hypoglycemic event. Right, so now these are another two cases I'm going to discuss. Now these are about patients we have started the GLP receptor agonist. So this particular lady from Kandy was started on liraglutide for weight management and diabetes, and 3 days later she's come in telling that, doctor, look here, this drug is not good for me. I have a pretty bad gastritis, I feel nauseous, I feel very uncomfortable even after eating few spoons of rice, and I don't think this is for me. Right? So this is one of the very common complications or common complaint that you are going to hear once you start semaglutide in your patients. So what has happened here? Right? This is not the traditional gastritis which is often self-diagnosed in Sri Lanka. The GLP receptor agonist works really by slowing the gastric emptying. So the problem is now her few spoons of rice, maybe like a half a plate of rice, and when she takes it, the stomach feels very full, it feels bloated, and she thinks that the drug is causing gastritis. So the management is small and frequent. So I asked her to reduce the portion size by half, and then the dose titration, better to start at a very low dose and then to gradually increase over weeks. And also the most important thing is we ask her to have drinks between meals, because nausea is worse when she is dehydrated. So these are the common side effects the patients report with GLP-1 receptor agonists. So they have nausea, vomiting, they feel, I mean, this is not an adverse effect, I would say, because it is a way that the drug works, and abdominal pain, and this was sulfur burps. And this, I had actually one patient, now he was started on semaglutide, and the biggest complaint is, doctor, I'm having a very bad breath, as if it's like a kunubittara wage. Gudus giyam kunubittara kandak enawa kiyala. So that is the typical sulfur burps described in GLP receptor agonist, because it slows gastric emptying. And with the slowing of the gastric emptying, there can be some fermentation happening inside your stomach, and you are going to get this sulfur burp. So again, the advice is to go slowly and to have very small frequent meals. And gallstone disease and pancreatitis are also known but uncommon complications of GLP receptor agonist. And then coming to another scenario, this is a 65-year-old retired teacher who has been on vildagliptin for 6 months. So she presents with joint pains in the knees and the wrist, and she says, "Doctor, I think I have got rheumatism. It's my old age. But the problem is I even can't have my morning walk because of this pain." Right. So this is one of the not very common but often described side effect of sitagliptin or vildagliptin, the joint pains. And often we tend to start these DPP4 inhibitors in elderly people, and they come after 1 month, they come with a joint pain. So we think it's another diagnosis. She has got osteoarthritis. We give some some medications and send them home. But always you need to think that this can be one of the complications of DPP4 inhibitors, which generally happens within first 6 months of initiation of therapy. So the easiest thing is give her a drug holiday, discontinue the DPP4 and see whether the pain resolves, and if it is the case, usually the pain resolves within weeks. So the adverse effects, the nasopharyngitis and headache, the common side effects of DPP4 inhibitors, and the GI upset, the joint pains and pancreatitis, and sometimes the rare case of bullous pemphigoid is associated with DPP4 inhibitors. Right. So coming to the last bit of my presentation, so we were telling, yes, in many patients for GLPs, but then we should know when to say no for GLPs as well. So medullary thyroid cancer is a strict contraindication, so it's not safe, but DPP4 inhibitors can be used. And history of pancreatitis, again you have to be very cautious in starting a GLP receptor agonist. Severe gastroparesis due to various reasons, again it's a relative contraindication to start on a GLP because that is going to make things worse. Pregnancy breastfeeding, we generally don't use them, and patients who have end-stage renal failure, GLP receptor agonist, you have to be a bit cautious as well. Right, so the take-home message of my presentation, so patients who have atherosclerotic cardiovascular disease, obesity, think about GLP-1 receptor agonist if your patient can afford. Elderly patients, frail patients, yes, who are at risk of getting hypoglycemia, think about DPP4 inhibitors before starting sulfonylureas, because you can prevent a life-threatening hypoglycemic event. In CKD patients, yes, unless they are in end stage, you can consider GLP receptor agonist or linagliptin. And if your patient has cost concerns, and if you want to give the benefit of incretin system, go for a DPP4 inhibitor. So yes, so that brings to the end of my presentation, and thank you very much for your patient listening.
Thank you very much, Chamara, for that excellent talk, applying the knowledge in very practical way. We comes to the last lecture. Last lecture is done by Dr. Sawandika Rupasinghe. She's a consultant physician in internal medicine attached to National Hospital, Kandy. She will talk us on SGLT2 inhibitors. Over to you, Sawandika.
Good evening, ladies and gentlemen. First of all, I would like to thank the President and Sri Lanka College of Internal Medicine for giving me this opportunity to present in this peer learning forum. As our final topic tonight, I'll be discussing about the evolving role of SGLT2 inhibitors as cardiorenal metabolic therapy and its practical implications for internists. Why do SGLT2 inhibitors matter in internal medicine, and why have I selected this topic tonight? SGLT2 inhibitors are unique because they are a single drug class with multi-organ benefit. And in our medical wards, we frequently manage patients with overlapping type 2 diabetes, CKD, and heart failure. This class of drug has demonstrated a reduction in hospitalization and mortality of such patients, making them highly relevant for physicians. So let me introduce Miss A, a 58-year-old lady with a background history of long-standing type 2 diabetes, hypertension, and a past history of myocardial infarction, CKD stage 3A, and albuminuria. Her HbA1c is 7.9, and she is currently on metformin and mixed-R insulin. So you're her physician, she visits you and says that a friend who has diabetes is on an SGLT2 inhibitor and she wants to know whether she is eligible for that. So let us explore the answer to her question through the course of this presentation. So in today's presentation, I'll be briefly discussing about the mechanism of action of SGLT2 inhibitors, followed by the clinical effects, evidence, indications, available agents, adverse effects, contraindications, and monitoring before coming back to our case for application. In normal individuals, 100% of the filtered glucose is reabsorbed in the proximal convoluted tubule of the kidneys, and 90% of this is done through the SGLT2 channels in the proximal convoluted tubules. So in normal healthy individuals, there's no glucose in urine. What SGLT2 inhibitors do, as their name implies, is blocking these SGLT2 channels, thereby reducing renal glucose resorption, which results in glucosuria and a reduction of plasma glucose. Since the co-transport is blocked, there's a reduction of sodium resorption, causing natriuresis and osmotic diuresis as well. So this reduces the intravascular volume, thereby reducing the blood pressure and the weight as well. And the reduction of volume causes a reduction in intraglomerular pressure, thereby reducing the preload and having cardiovascular benefits. SGLT2 inhibitors also promotes vasodilatation and improves endothelial function, reducing the afterload, again having cardiovascular effects. And when there's increased sodium delivery to the macula densa, there's constriction of peripheral arterioles, causing a reduction in glomerular hyperfiltration, slowing the rate of kidney disease progression. So with these mechanisms, they have three major effects: metabolic effects by glucosuria and plasma volume reduction, cardiovascular effects by reducing the preload and afterload, and renal effects by reducing the progression of end-stage kidney disease. So the main metabolic effects are a reduction of HbA1c, a reduction of weight, and a reduction of blood pressure. The cardiovascular benefits includes a reduction of heart failure events, reduction of cardiovascular mortality, and then renal events are mainly reducing albuminuria and reducing eGFR decline. So with those effects, they have three main indications. As you all know, they are used in patients with type 2 diabetes with either established or high-risk atherosclerotic cardiovascular disease, in patients with diabetes and heart failure, and in patients with diabetes and CKD. And they are also indicated in patients with heart failure, all types of heart failure with reduced ejection fraction, preserved and mildly reduced ejection fraction. And they are also indicated in patients with CKD with albuminuria, but the eGFR should be 20 or above. So if the eGFR is less than 20, SGLT2 inhibitors are contraindicated. So what is the evidence supporting these benefits? I'll just summarize the trials into four as cardiovascular outcome trials, renal trials, heart failure trials, and three other trials among acute and special populations. Moving on to cardiovascular outcome trials, there are four trials. Out of that, the first three you can see here: the EMPA-REG outcome for empagliflozin, CANDIS program for canagliflozin, and BERTI-CV for ertugliflozin were conducted in patients with type 2 diabetes with established or high-risk cardiovascular disease. In contrast, the last trial, the declarative 58 for dapagliflozin, was conducted in patients with type 2 diabetes, and the majority didn't have established or high-risk atherosclerotic cardiovascular disease. Interestingly, the primary outcome of all these trials were a reduction in major adverse cardiovascular events, whereas the secondary outcome were a reduction in cardiovascular deaths, a reduction in heart failure hospitalizations, a reduction in all-cause mortality, and also a reduction in progression of nephropathy, albuminuria, and slowing the eGFR decline. Moving on to the renal outcome trials, there are three main trials. Out of these, the first one you can see here, the Credence trial for canagliflozin, was conducted only in type 2 diabetes patients with albuminuric CKD. But in contrast to that, the other two, the DAPA-CKD for dapagliflozin and EMPA-KIDNey for empagliflozin, were conducted in patients with CKD irrespective of their diabetes status. And the outcome of all these trials were a reduction in renal composite, like a reduction in eGFR decline and albuminuria, whereas the secondary outcomes were cardiovascular benefits. Moving on to the heart failure trials, the first two here, the DAPA-HF for dapagliflozin and EMPEROR-EUS for empagliflozin, were conducted in patients with reduced ejection fraction. The EMPEROR-PRESERVE for empagliflozin was conducted in patients with preserved ejection fraction, and DELIVER for dapagliflozin were conducted in patients with preserved and mildly reduced ejection fraction. And the primary outcome of all these trials were a reduction in cardiovascular deaths and heart failure hospitalizations. So they can be used in any type of heart failure. And the secondary outcomes were renal outcomes and a reduction in all-cause mortality. And there are three additional trials: SOLOIST WHF for sotagliflozin, which was conducted in type 2 diabetes patients with recent worsening heart failure, which concluded that they reduce cardiovascular deaths and heart failure events. And EMPAS for empagliflozin was conducted in patients with acute decompensated heart failure, and that also showed that there was clinical benefit at 90 days. And the last trial, attempt trial, which came out in 2024, was conducted in type 1 diabetes patients. The population was aged between 12 to 21 years, pediatric and adolescent population, and the conclusion was that they reduced albuminuria, HbA1c, systolic blood pressure, and weight. So it can be used in type 1 diabetes. The starting dose is 5 milligrams once daily, but with caution and monitoring, because there's a high risk of DKA, and I have seen it being used commonly in other countries like the United Kingdom and Australia. So this is a meta-analysis, a summary of all, showing that SGLT2 inhibitors have benefits beyond glycemic control. And this is a summary of evidence-based indications. So type 2 diabetes with established or high-risk atherosclerotic cardiovascular disease, type 2 diabetes with any type of heart failure, type 2 diabetes with CKD, and heart failure of any type, reduced, preserved, and minor reduced ejection fractions. CKD defined as an EGFR 20 or above with albuminuria, defined as a UACR of 200 milligrams per gram or above, and in patients with acute decompensated heart failure, and in type 2 diabetes patients with recent worsening heart failure. And as you all know, these can be used in patients with type 2 diabetes in addition to metformin and lifestyle changes when there's a risk of obesity or hypoglycemia as second line or third line agents, because SGLT2 inhibitors causes a weight reduction and they have a very low risk of hypoglycemia. So moving on to our patient, Miss A, so she eligible for this? Yes. So she has type 2 diabetes with established atherosclerotic cardiovascular disease. She has CKD, and EGFR is about 20, and she has a UACR about 200 as well. And the expected benefits for her would be a reduction in cardiovascular deaths, a reduction in heart failure hospitalization, a reduction in CKD progression, and lowering albuminuria. So you decide to start her on an SGLT2 inhibitor. And now she wants to know about the available subtypes, side effects, contraindications, and monitoring. So how would you advise her? So here are a few available agents worldwide, but in Sri Lanka we commonly use dapagliflozin and empagliflozin. Dapagliflozin, the starting dose is usually type 10 milligrams once daily, and EMPA is 10, but you can increase it to 25 milligrams once daily, and both are taken with or without food, it doesn't matter, preferably early in the morning to avoid nocturia. So moving to adverse effects of SGLT2 inhibitors, hypertension is a common adverse effect caused by the transient initial volume loss. So it's very important to review patients' medications, especially antihypertensives and diuretics, and adjust the doses before starting SGLT2 inhibitors. And urinary tract infections are another common adverse effect, ranging from simple ones like UTIs, balanitis, or vaginal candidiasis to complicated infections like Fournier's gangrene. And diabetic ketoacidosis and euglycemic ketoacidosis are another common adverse effects. Then rare adverse effects includes canagliflozin-induced bone fractures and amputations of lower limbs. So they are very rare. Hypoglycemia with SGLT2 inhibitors per se is uncommon, but they can cause hypoglycemia when used in combination with other agents like insulin or oral hypoglycemics. So this slide illustrates some factors that precipitate SGLT2 inhibitor-induced diabetic ketoacidosis. So where conditions can be divided into two as conditions where there's intravascular volume depletion like diarrhea, vomiting, exercise, or ketone-prone states like reduced oral intake, alcohol, inpatient hospitalizations, LADA, surgery, or severe hyperglycemia. So there's a mnemonic as well called derails. So it's better to avoid SGLT2 inhibitors in such patients. So what are the absolute contraindications? Active DKA, pregnancy all trimesters, breastfeeding, and known hypersensitivity. So these are the absolute contraindications. And moving on to relative contraindications, type 1 diabetes is a relative contraindication. So if you are using it, you have to be cautious and monitor for DKA. But the attempt trial has shown that it can be used in type 1 diabetes with kidney disease. And then EGFR below agent-specific threshold is another relative contraindication. So it's 20 or above for empagliflozin, EGFR 25 or more for dapagliflozin, and 30 or more for canagliflozin. And if a patient has recurrent genital mycotic infections or previous DKAs, or the factors I mentioned in the previous slide precipitating DKA, these are all relative contraindications. And it's better to avoid this in frail patients with low BMIs because there's a risk of ketosis and dehydration. So now you decide to start Miss A on an SGLT2 inhibitor. So how would you monitor her? So before starting, it's important to do a baseline assessment, including checking the volume status, specifically a postural blood pressure, and then do a metabolic profile with HbA1c and fasting blood sugar renal assessment, and also take a thorough history to exclude the contraindications. Apart from these, in patients who will start dapagliflozin, a baseline liver profile should be done because dapagliflozin is contraindicated in severe liver disease. And also in patients with canagliflozin, before starting, it's better to do a bone density scan if they are elderly, frail and vulnerable. So once you start, you have to follow up the patient in 1 to 4 weeks' time and assess the volume status, blood pressure and renal functions. So within the first month of starting therapy, an eGFR drop of 30% or less is expected. This is due to the reduction in intraglomerular pressure. But if this eGFR drop is above 30%, then you have to stop the drug and evaluate for a cause for AKI. And then the patient should be monitored every 3 to 6 months with weight, blood pressure, glycemic control, albuminuria, and renal function. But if the eGFR is above 60 and if the patient has good glycemic control, then you can even follow up annually. But if the eGFR is less than 60 and there's suboptimal glycemic control, then the patient needs more frequent follow-ups, like 3 to 6 monthly. So revisiting our patient, you start her on empagliflozin 10 milligrams once daily, and 1 month later she presents to you with a 1-week history of itching and whitish discharge in the genital area. So she doesn't have fever, chills or urinary symptoms. HbA1c is 7.5. So how would you manage her? So here she doesn't have fever and no symptoms of UTI. So she has simple vulvovaginal candidiasis. And HbA1c seems to be fine, like 7.5. So what you should do is to treat this infection with fluconazole and hold dapagliflozin for the time being because HbA1c is reasonable. But if she comes to you with recurrent infections or with severe infections, then that's an indication to withhold or stop the drug. So what advice would you give her? Advise her on preventive strategies like drinking plenty of water, maintaining personal hygiene, regular bladder emptying, and wearing appropriate underwear. So now you review her at 6 months, and her HbA1c has reduced, the weight has reduced, blood pressure has improved, eGFR is stable, albuminuria has reduced, and she hasn't had any hospital admissions with heart failure, and overall her quality of life has improved. So in our patient, Miss A, appropriate SGLT2 inhibitor initiation has resulted in improved glycemic control, reduced albuminuria, stabilized renal functions, and has lowered the cardiovascular risk. So it's always important to select the right patient and start these at the right time, which will give you a right outcome. So this is a summary of SGLT2 initiation. So you initially have to confirm whether there is a clear indication, then check the eligibility. The eGFR should be above 20, and review medications, especially adjust the doses of antihypertensives, diuretics, insulin, and oral hypoglycemics. Then initiate the SGLT2 inhibitor, and then educate the patient and monitor and follow up the patient. So this brings us to the end of my lecture tonight, but before I conclude, let me draw your attention to a few important and clinically significant facts which are worth remembering about SGLT2 inhibitors for our day-to-day practice. So interestingly, SGLT2 inhibitors have a low glucose lowering effect, and the expected HbA1c reduction would be 0.5 to 1% if you use them for 6 to 12 months. And the glucose lowering effect is reduced when the eGFR drops below 45, but still we use it. Why? Because they have cardiovascular and renal benefits. And as I mentioned before, they are contraindicated to initiate if the eGFR is below 20. But once started, you can continue them even if the eGFR falls below 20 until the initiation of dialysis or transplant. And also, SGLT2 inhibitors are known to cause secondary polycythemia by increasing renal erythropoietin. So a hemoglobin rise of 1 to 2 grams per deciliter is expected within the first 2 months of therapy. And due to the early transient plasma loss, an early rise in hematocrit is expected. And the weight loss that is expected is 1.5 to 3 kilograms if you use them for 6 to 12 months. And I mentioned before that canagliflozin is associated with fractures, which is a very rare side effect. The pathophysiology of this is quite debatable. So some say that SGLT2 inhibitors increase renal phosphate resorption, thereby increasing FGF23 and reducing vitamin D levels, causing low bone mineral density. But others argue that these fractures are secondary to falls from orthostatic hypertension. And finally, SGLT2 inhibitors have an antiarrhythmic effect and can be used in patients with heart failure with arrhythmias like atrial flutter, atrial fibrillation, and ventricular arrhythmias. So in summary, SGLT2 inhibitors are cardiorenal metabolic drugs, and the indications go beyond glycemic control. They can be used in renal and cardiovascular events as well. And safety requires structured monitoring, and case-based selection, like our patient, improves real-world outcomes. So these are the references. Thank you for your attention.
Thank you very much, Sawandika, for very informative talk. So along with that, we conclude all three presentations. I'm sure you all have very questions and ideas to share with. May I ask all three speakers to present on the stage for the case discussion and sharing opinions. Dr. Kumudini Jayasinghe, Dr. Chamara, Dalugama, and Dr. Sawandika Rupasinghe, please be present on the stage.
My question to Chamara, when you say that GLP-1 agonist, what are the recommendation of combining with insulin and other drugs with this agonist, GLP-1 agonist?
Yes, I mean, that is indicated because even with patients who are on insulin and GLP can have additional benefits with regard to improving the organ functions and improving the cardiovascular morbidity and mortality. So even the patients who are on insulin, because insulin is a drug that controls the blood sugar, but we do see patients gain weight when they are on insulin. So combining insulin with the GLP-1 agonist would be a good choice to get the weight reduction and to have the other advantages.
Right. Thank you, John.
This question is from Sawandika. In a normal ward setup, if we are treating for, as example, we are treating a patient for pyelonephritis, but she has all the indications to start on empagliflozin. Is there any contraindication in starting the empagliflozin for an in-ward patient who is on treatment for infection?
There's no like clear guidelines, madam, but it's better to treat the infection first and start it because the patient might not be having proper appetite, and there could be like there's a risk of ketosis as well. And since the patient is a diabetic, there's a risk of precipitants of decay as well. So it's better to avoid it, to treat the infection, and then start it.
Okay, thank you.
Thank you for all three speakers. It was a wonderful session. My question goes to Professor Chamara. You went through the molecule GLP-1 agonist and the wonderful benefits of it. And I just wanted to get your viewpoint on, there's a lot of evidence coming up on the weight loss with GLP-1 is a sarcopenic weight loss. There's lots of muscle wasting associated with it. And also there is a lot of evidence on rebound weight gain, because they're talking about the duration of GLP-1 agonist, and once you stop the drug and they see a sort of sudden burst of weight gain coming back to their old weights. So I just wanted to get your viewpoints on that.
Point that you made, because when you keep the patient on, when you start the patient on a GLP receptor agonist, and then you do see a very nice loss of weight, but after stopping the GLP receptor agonist, sometimes we do see that not to the fully extent, but to certain extent that they gain weight. So because of that, we need sort of a maintenance that you need to have maintain the medications as well. But in a country like us, that will be a bit of a concern because of the financial issues, right? And the other thing is, although they gain weight, but there are certain things that which has got reversed. Say for instance, a patient who has a in a pre-diabetic stage, but with the GLP receptor agonist, the patient has reverted back to the normal stage. Or the patient who has fatty liver, the steatosis has improved, and these effects are they have a sort of a legacy effect which lasts longer, but again the weight-wise, they can go back to their normal weight after several months of stopping the medications, but again we need to advise them on the lifestyle modifications as well. But when it comes to sarcopenic changes, it is a matter of selecting the appropriate patient, right? So sometimes when we select a patient who has a lot of central obesity, central adiposity, we see a good response. But in a thin person, yes, we do see that not only the fat, but they lose their muscle as well. So that is something that we do observe.
Can I ask one question from Sawandika? Is there any age limit to start SGL2 inhibitors? What's the age limit that you start SGL2 inhibitors? Even in frail and elderly still that you start?
There's no relevant age limit in guidelines, madam, but it all depends on the comorbidities and frailty. Like if the patient is at high risk of falls or static hypertension, then it's better to avoid. I guess it's like a case by case. It differs from case by case. It depends on the patient's comorbidities, background history, and all. So risks versus benefits. You'll have to calculate that and then start. There's no specific age limit.
The experience now when we start these patients with heart failure, the very elderly people, the SGL2 inhibitors, then they come with a severe dehydration and the kind of sarcopenia.
Yes.
So
there's no guidelines. There's no specific age limit, but if you start, you have to advise the patient on proper hydration thoroughly and the importance of these and side effects and all. So it's all about risks versus benefits and patient's education level. How patient will follow up all this advice and all. So it depends on case.
I have a question to Prof. Chamara Dalugama. Just wanted to know now when your patient has established CVD and type 2 diabetes, and which one would you want to start, SGL2 inhibitor or GLP-1RA?
Right. Okay. So that I think because of the trial shows both agents are beneficial, and there is no harm combining the two agents as well. So there are different trials which show certain benefits of in both classes of the drugs. So it's no harm to start both of the medications, because SGLT2 inhibitors, whenever there is indication, we do start because it's cost effective and it is easy to take, and then so that's maybe the first line. But then with that we will see whether that's indication for a GLP-1 receptor agonist, particularly if the patient is obese or if the patient has suboptimal HbA1c with all the other medications, or if the patient likewise we have to go case by case. And I think if I am to select both agents, I would certainly start SGLT2 inhibitor first, because it is easy to give and it's cost effective. And then second, I would consider adding the GLP-1 receptor agonist, considering the patient's other factors like the financial ability, because at the moment it's not freely available in the government sector, and it costs roughly it will be cost in around at least 25,000 to 50,000 rupees per month, and the patient should be able to afford. So that will be a major consideration when I am to select a GLP-1 receptor agonist.
Another question, in fact this is out of the topic that you have discussed here. Now these two main drugs, diabetic newer drugs, we know that there's cardiovascular and renal benefits. But I want to know actually the insulin have been used longer days, we have been using it. We know that the proper control with diabetes to the target with any of the drugs, you get less microvascular and macrovascular complication. Whereas the insulin per se has any pleiotropic effects like these two new drugs in terms of cardiovascular benefits or CKD, morbidity, mortality benefit? I hope you got my question.
Yeah, I got the question, and I was thinking like now insulin. There are no. I'm not very sure about the trials which has looked at the cardiovascular benefits, but they have looked at the good HbA1c control versus the improvement of the cardiovascular function, so the renal impairment. Like if you have a HbA1c which is very well maintained and without any fluctuations of the blood sugar, that is good for the heart, that's good for the kidney. But as a molecule, insulin per se, whether it has other pleiotropic effects in addition to the glycemic control, like what we always talk in GLP receptor agonist is glucose independent effects on the heart, effects on the kidney, which I'm not sure whether the insulin possesses the same independent effects on the heart other than the glucose lowering effect, because insulin does cause weight gain, and then so I'm not very sure about whether that is independent effect.
So in that case, actually now that we have these new drugs are coming up, I think we have oral semaglutides available, not actually freely, expensive. In instance, somebody on a type 2 diabetic patient with oral hypoglycemic failure on insulin could be switched to these new drugs, possible, isn't it? People who have 4-week for insulin and various other things.
Yeah, but the issue would be, I think, now this GLP receptor agonist, they work on the pancreas and they stimulate the insulin synthesis. So if there is the pancreatic failure, so in that case, the incretin system will not work. That is the very reason why, compared to a normal person, a type 2 diabetic has a very blunted incretin response. So in that case, in such a patient, purely starting on semaglutide might not enough to get the blood sugars down. So then we might have to have a combination with insulin, and to sort of augment the effect, we can use the GLP-1 receptor agonists.
SGL2 inhibitors in that case?
Well, SGLT2 inhibitors.
But it act in a different site in a different way, isn't it?
Yes, you can't use it instead of insulin because the glucose lowering effect of SGLT2 inhibitors are minimum. Like they cause a very 0.5 to 1% of HbA1c reduction in contrast to insulin. But you can use them in combination with insulin.
Yeah, that's a good question. So you were on.
Yeah. Now, Chamara, excellent presentation. Now, I want to share my experience with the semaglutide. One important side effect is constipation. I think most of them, they complain of constipation. Very common. And how do you feel about the constipation? How to avoid? Yeah, I mean, it's very common.
Yes, I agree, sir, because it slows the stomach, slows the whole gastrointestinal system. So because of stomach slowing, they complain of a lot of fullness, and in the other end, they have constipation as one of the common side effects.
And the big belly is a good drug for big belly, actually. They are very happy to take it. And the good news is the price will come down after April, Chamara. This what you call this patents will be over in April. So semaglutide price will come down after April. This is good news. And Dr. Rupasinghe, you said this euglycemic ketoacidosis is common. I don't think it's common in our setup. This is my experience. I don't now you can ask others. It's not very common in our people. I haven't seen many patients with euglycemic ketoacidosis.
Yes, sir. I mean, so it was common in compared with those bone fractures and all, but not very common.
Not very common actually. Yes. It's not a common problem in our population.
Yes, precipitating decay is commoner than that actually.
Yes.
I also have one simple question from Professor Chamara. When it comes to pre-diabetic, I think it is which drug you think that the best for the pre-diabetic who becoming diabetes or to prevent diabetes, which drug is the best one?
Right. I think it depends on the patient factors as well. Now, if that is like a patient with a BMI of 30, and then I will be mainly targeting at weight loss, because we can go for a sort of a remission of diabetes. So in that case, a drug that will have effects on great effects on weight loss would be ideal. So in that case, the weight loss that we really expect from metformin is not great, but then we can use drugs like semaglutide or even the tirzepatide. It has a even higher reduction of weight. So in appropriate patients, we can select and we can titrate it accordingly to the expected weight loss, and then we can sort of get them cured from diabetes.
Yeah, if I'm correct, I think tirzepatide has the highest percentage, right? That is the best drug to prevent,
Yes.
considering the other factors. But is it used in practically? I mean, are we trying to prevent pre-diabetic going into diabetes by using drugs like tirzepatide?
Not always, but certainly in patients with very high BMI and who has impending risk of getting into diabetes with other complications, like they have elevated liver enzymes, their triglycerides are very high, and they have a very BMI, and then HbA1c is also like around 6.4, 6.5, and then the drug aiming to lose weight would be the ideal to sort of mitigate all the complications from this, the whole picture of this patient, like the liver, the triglycerides, and the diabetes. So in that instance, if the patient can afford, I think it's a drug that we can try.
Thank you.
Okay, in the absence of this, we'll conclude this question session. Let us applaud all three speakers in a usual way for the excellent talks that we were able to listen. Thank you very much. Now let me cordially invite our President, Dr. Madhuwanti Hettiarachchi, to hand over the token of Certificate of Appreciation, Dr. Kumudini Jayasinghe. Thank you everyone for your active participation and sharing your valuable thoughts. Now let me invite our co-secretary, Dr. M.N.M. Yusuf, to address you with vote of thanks. Thank you.
Good evening all, it's nice to be back in Kandy. It is indeed a privilege to deliver the vote of thanks on behalf of the Sri Lanka College of Internal Medicine in my capacity as Joint Secretary at this peer learning forum for consultants. First and foremost, I extend my sincere gratitude to Dr. N. Madhuwanti Hettiarachchi, President of the Sri Lanka College of Internal Medicine, for inspiring welcome address and for her steady leadership in fostering academic excellence within our college. My heartfelt thanks go to our moderator, Dr. Tushari Vanigaratna, for steering today's discussions with clarity and balance, ensuring a meaningful and engaging exchange of ideas. I would like to place on record our deep appreciation to our distinguished resource persons, Dr. Kumudini Jayasinghe, Professor Chamara Dalugama, and Dr. Sawandika Rupasinghe, for generously sharing their expertise and valuable clinical insights. Your contributions have truly enriched this forum and strengthened the spirit of peer learning. A special word of thanks to Professor Priyamali Jayasinghe for meticulously arranging this academic program and maintaining a high academic standard as well. I also wish to sincerely thank Dr. Chaminda Kotage, our central coordinator, for his invaluable coordination and efforts in bringing this program together smoothly. Your behind the scenes work has been instrumental to its success. Our gratitude extends to Dr. Aruna and the audiovisual team for their seamless technical support, Mr. Chaminda Karunaratna, our photographer, for capturing these memorable moments of this forum, preserving them for our college archives and future reflections. We also thank the musical band for adding warmth and elegance to the occasion, which is to follow. We are grateful to Mr. Tusit and the staff of the Grand Candian Hotel for their excellent hospitality and arrangements, which created a welcoming and a professional atmosphere for this event. My appreciation also goes to the dedicated office staff of Sri Lanka College of Internal Medicine who worked tirelessly behind the scenes to ensure everything went efficiently. We deeply value the generous support of our sponsors, namely Mr. Chatura, Mr. Rajiv, and the team AstraZeneca for our partnership with us advancing academic initiatives. Finally and mostly importantly, I thank all the participants. Your engagement and commitment to continuous learning reflect the true strength of the College of Consultants Learning Forum for the betterment of patient care. Thank you all again for making this forum a meaningful and a memorable success. Have a pleasant evening ahead.
While you are getting ready, I think since today is a very special day, Valentine's Day, let us remember that love is all around us, in our friendships, in our work, and in the bonds we share. As we conclude this program, I invite all of you to enjoy the fellowship and dinner. Thank you very much for joining with us.